This is pharmaphorum web editor Nicole Raleigh on site in Berlin for ESMO 2025, and as the Congress comes to a close, I have with me Dr. Sandeep Reddy, who is Chief Medical Officer at ImmunityBio. Pleasure to speak to you.
Thank you. Pleasure to be here.
So actually the pharmaphorum audience might remember that Dr. Reddy and I had a previous conversation at ASCO this year on the importance of FDA Expanded Access authorisation for its Cancer BioShield platform anchored by ANKTIVA. Now, ImmunityBio is on a mission to continuously pursue new therapies that kill disease, not the immune system. Indeed, there's a surge of innovation happening in the non-muscle invasive bladder cancer space at the moment. And with multiple late-stage trials reporting results, physicians and patients are carefully weighing both opportunity and the risk. As these results emerge, though, there's growing debate in the field. Should BCG-naive patients be exposed to checkpoint inhibitors, or are there safer, bladder-sparing alternatives that preserve efficacy without the same risk profile? So, Sandeep, firstly, can you please speak to this concern in a general sense for our viewers?
Sure, absolutely. First of all, I appreciate the question. There's been two very large trials reported recently. Earlier this year, there was the CREST trial, and now at this meeting, there is the Potomac trial. Both of these trials are looking at the BCG-naive, non-muscle invasive bladder setting, in which BCG is the standard of care, and now we're adding a checkpoint inhibitor. In the CREST trial, it was sasanlimab, which is a sub-Q checkpoint inhibitor. In this trial, it's durvalumab, which is an IV checkpoint inhibitor. But in either case, it's a checkpoint inhibitor. And to your point, the question is benefit versus risk. So both trials showed a benefit in terms of disease-free survival. It's small. It's about 5% of the most recent data from the Potomac trial in terms of an improvement in disease-free survival for these patients over BCG. That 5% does come in some cost. There's added economic cost, but more importantly for the patients, the toxicity cost. Now, what was interesting is in the current trial, the Potomac trial, there was no grade 5s, there was no deaths. In general, we know that there's a small risk of severe life-threatening immune-related toxicity. And I think that's ultimately the question that the field will have to decide. You have a disease, non-muscle invasive bladder cancer, which generally doesn't rapidly progress to death. In fact, in the trial, there was no difference in overall survival. So one has to weigh those things. I think we don't know the answer to that. I mean, there may be subsets of patients who we might discern as most highest risk, and might benefit from that intensification of therapy. And then there's other patients who may have other comorbid illnesses or other reasons to forego that therapy. So I think it's still a patient selection question. Separately, we're trying to answer that, as you mentioned, with other trials. So we have an ongoing global trial called QUILT 2005 in the BCG-naive space. It's not involving a checkpoint inhibitor. It's involving our drug ANKTIVA in combination with BCG versus BCG. One of the benefits is it's given into the bladder at the same time as the BCG. And so it's a little bit easier for the patient. Instead of the patient receiving something in their bladder and something in their vein, that inherent logistical complexity, I think, is challenging. And if it's all given at the same time in the same place by the same physician, that could be easier. Ultimately, it has to work and it has to be safe. And we're waiting to see, hopefully in the next few months, we'll fully enroll that and we'll maybe have data by sometime late next year to report.
Thank you. So I was wondering if you could also provide your perspective on turning to ANKTIVA, the FDA-approved IL-15-based immunotherapy for BCG unresponsive NMIBC. That is also being studied in this BCG-naive setting.
Correct, and that's this trial I'm referencing. And the benefit of ANKTIVA is the mechanism, as opposed to a checkpoint inhibitor. This is a cytokine fusion protein. So what is that? What's the difference? The checkpoint inhibitors are blocking the immune response. They're taking the brakes off to accentuate the immune response, to activate those T cells to kill the cancer. However, some of those T cells can be autoimmune. They can attack the cells and cause these toxicities that we're seeing. In our case, what we're doing is we're activating mostly NK cells, natural killer cells. Now, we also activate killer T cells, but we don't activate regulatory T cells, which are immunosuppressed there. So it's very specific in its activation, NK cells, the way that they kill tumors is very specific. It's direct cell to cell. They're not releasing a lot of cytokines. And so the patients don't experience increased toxicities relative to BCG itself. So that's a nice thing. And there, at this point, does not seem to be any serious immune-related, checkpoint-related, life-threatening kind of toxicity. So I think that's an advantage. I think the other advantage that I mentioned is the convenience aspect. It's being given in the bladder, which of course is where the disease is. I think it's a first principle in medicine that you want to treat where the disease is rather than treat the entire body for a disease that might be in a localized area.
Yeah, particularly in the oncological setting,
Absolutely.
given the toxicity risk with a lot of the treatments.
That's exactly right.
So if we think more generally now, there's been a lot of talk at ASCO 2025 about new standards of care. So how is new science, and you can be as general, as wide-ranging as you like, going to reshape the standard of care as is now?
Well, I think the major trials that reported here that were important, at least in the context of bladder cancer, were more about muscle invasive bladder cancer and looking at ways to preserve the bladder ultimately. So effective, we would call them neoadjuvant therapies that we've now seen can substantially reduce the amount of tumor that's present, to the point that one has to question whether a radical cystectomy is necessary in that patient when we're seeing very high pathologic complete response rates. That's number one. Number two, there's some data now on being able to follow these patients or stratify these patients using ctDNA tests. And so what they're seeing is that in the ctDNA negative patients at that point in time, it looks like, it's maybe too early to say, but may be cured. And do they need additional therapy? So if all of that is true, could you get to a place where you give a very effective, highly effective therapy, both systemically, but also to the bladder, and thereby control all the disease, eliminate disease, do some type of circulating DNA test, urine-based DNA test, maybe a combination of both, but show that there is no residual tumor. And now at that point, the argument for taking the bladder goes away. There's no disease, things are under control, we can observe that patient. So those are patients that for the last, 50, 100 years, we've taken their bladder out. And now we might be able to put them on a different path. So that I think is very exciting. The science supporting that is some of these new DNA assays, but it's also the effectiveness of the drugs. And then where we think we can come into play is about a third to 40% of these patients, even with muscle invasive disease, we might make their muscle invasive component go away, but down the road, they have local recurrence of non-invasive disease in their bladder. And could we perhaps forestall that, prevent that, completely eliminate that risk by giving some therapy to a bladder? Right now, that's not occurring. All the therapy is being given into the vein. But what if we gave it into the bladder as well? And I think because of the toxicity profile of ANKTIVA, which is very mild, it could be successfully given in that circumstance into the bladder and help prevent any of those non-muscle invasive recurrences. And that I think would be a big boom for our patients.
And so actually there was some very interesting data presented by Mars today on our ctDNA. So thank you for raising that for our viewers. So my next question, what are ImmunityBio's next intentions, if you may?
Sure, absolutely. Well, first of all, I'll go back to your question to go forward, which is at this conference, we did present additional data. We had a poster session in which we showed some data related to one of our non-small cell lung cancer programs. And what we showed is that in a randomized trial called QUILT 2023, when we gave our drug ANKTIVA subcutaneously, so not in the bladder, but subcutaneously, what we see is a statistically significant separation in the level of the absolute lymphocyte count over time. So what we know is that when we want to give an immunotherapy, we need the immunotherapy to work via the immune system. Well, the immune system in this case is the T cells. And without T cells, whatever immunotherapy we give, it's unlikely to benefit the patient. So we can measure that by looking at the absolute lymphocyte count. The lymphocytes are B cells and T cells and NK cells for the most part. And when we see that when given a checkpoint inhibitor, the patient generally stays stable or decreases over time. But when given ANKTIVA and a checkpoint inhibitor, they increase and stay up over time in a statistically significant manner, what we're saying is this is really a growth factor. This is a growth factor that can grow the cells that are needed to make all of these other therapies that we're so excited about. Or at this meeting, we're talking about bispecifics, we're talking about CAR T cells, we're talking about other immunologic modalities, secondary checkpoint inhibitors, but all of them are working through activating the immune response. But if those cells aren't present, if they've been killed by chemotherapy, if they've been suppressed by radiotherapy or other therapies, we can use ANKTIVA to bring those cells back up and then get a bigger response with these therapies that we're developing. So that, for us, is the future. That's the science we're looking at. We have a global non-small cell lung cancer trial that's testing this hypothesis called Rescue 201. It just launched. We've enrolled our first few patients. We're looking at expanding the sites. But in that trial, that's after checkpoint failure. So patients have had a checkpoint. It's not working anymore. We can give them ANKTIVA in combination with tislelizumab and 2 cycles of docetaxel. And we think that combination will be enough to reinvigorate that immune response and give those patients long-term disease control.
Thank you.
Thank you.
So, exciting science. Yeah, very much so. And there's been a lot, as you alluded to, of exciting science at ESMO 2025. So, if I may, going in more widely than what we've been discussing right now, what have been the key takeaways for you? Now we'll blend that with a final question. Given those key takeaways, what could oncology look like in the not too distant future?
Wow. Well, I think the key takeaways are that, first of all, we know that immunotherapy is here to stay. For example, that the EV, forty-five vedotin data that we just recently discussed, we had seen the previous data. We knew that this was going to look good, but the hazard ratios are really, really good. They're very impressive. So it's more of confirmation of the things that we thought we would see. We're seeing that. That in fact, the antibody drug conjugates with the checkpoint inhibitors are effective therapies, and they're working across broad groups of tumors. Second, the bispecifics seem to be holding in terms of their benefit. So if we combine these with other therapies, for example, ANKTIVA, a cytokine, I mean, that's where I think you need to go as a community. What are the right combinations or what are the right sequences in these drugs to put together? We certainly feel like, based on the toxicity profile of ANKTIVA, it can partner very well with these other medications. And the mechanism story partners very well. Whereas some of these other options that we've looked at in the past, which is secondary checkpoints such as TIGIT, that just hasn't panned out. So the biology is speaking to us and we have to chase that. The science is speaking to us, we have to chase that. So I think it's a very exciting time. Lastly, I will say that I didn't see enough of the cell therapy things here at ESMO. Perhaps those were being held for ASH or some other meetings, but I think cell therapy still continues to be a very meaningful and significant modality. Perhaps not as much in solid tumors, certainly in others. And bringing cell therapy into solid tumor, combining those with some of these agents is also the next big play. We certainly feel that the NK cells have a very significant role, complementary role to play in addition with these other cells. That's always been our central hypothesis, is that there's a reason that our bodies have both an innate and adaptive immune response. And we should probably try to take advantage of both if we're going to be successful for our patients.
Well put. Thank you for your time today, sir.
Well, I appreciate it. Thank you so much.